with Professor May Nassar. I'm very glad and happy to be with you in this Congress. Over the next 20 minutes, I would like to share with you some updates on celiac disease in children. As we know all, celiac disease is the most commonly genetically induced food intolerance worldwide, with the prevalence about 1% and still growing. This is a most common autoimmune condition triggered and sustained by the ingestion of gluten, which is present in the wheat, rye, and barley in genetically susceptible individuals. This will cause an inflammatory damage to the mucosa of the small intestine, resulting in a variety of clinical presentation. If you leave this untreated for a long time, this will lead to nutritional complication and increased mortality. Looking at the typical picture of celiac disease almost 100 years ago in the United Kingdom, this was the classical picture of celiac disease with malabsorption, protruded abdomen, wasted buttocks, severe malnutrition, but we don't see such a picture nowadays in our practice. We are seeing opposite of this picture, children with obesity, children with constipation, so atypical manifestations of celiac disease. If you want to look at the prevalence of celiac disease based on biopsy or based on screening data by serology, you can see whether the studies conducted in Europe, North America, South America, and other parts of the world. Still, the prevalence is very high, reaching in biopsy-proven disease to 1% and serology-proven disease to 2 to 3%. And like many autoimmune disease in practice, it's always a genetic interaction with the environmental trigger. We don't know what happened that the environment will trigger the disease in genetically susceptible individual. It could be gender related, could be infant feeding practice, could be infection, exposure to radiation, and so on and so forth. We as a pediatrician or general practitioner are very good in detecting the typical GI presentation of celiac disease with diarrhea, vomiting, failure to thrive, abdominal bloating, pain, and constipation. This is very typical and easy to pick up manifestations of celiac disease. But what about atypical or other phase of celiac disease? We are seeing this more and more nowadays. So, for example, short stature, about 10–15% of all short stature children are presenting with like celiac disease. Osteopenia, dental enamel hypoplasia. Very important indication to screen for celiac disease is iron deficiency anemia resistant to treatment. As you know, iron deficiency is very common, happen in 30 to 40% of school-age children. If you have a child who's taking iron for at least 3 to 6 months with good compliance, he or she is not getting any better, think about malabsorption and think about celiac disease as a cause, because we know that iron gets absorbed in the second part of the duodenum. If you get mild elevation of liver enzymes, so 2 to 3 times upper limit of normal, this is another possibility of celiac disease. Arthritis, neurological disease, fatigue, behavioral changes, reduced female fertility or pregnancy, like recurrent abortions, all these are atypical manifestations of celiac disease. So if you want to illustrate this in a cartoon, we are very good in detecting the tip of the iceberg, so symptomatic celiac disease cases. And this will be manifesting by mucosal lesion with villus atrophy and other changes. But what about silent or latent celiac disease? So those who have normal or slightly abnormal mucosa and minimal symptoms and maybe positive serology. These are challenging part of celiac disease iceberg. These are high-risk groups in which a pediatrician or a healthcare provider should screen for celiac disease. So our endocrinology colleagues are very good in screening all children with type 1 diabetes every year for celiac disease with TTG and total IgA. So the prevalence reach 8% in type 1 diabetes and Down syndrome. This is between 5 to 12% in autoimmune thyroid or liver disease. Turner syndrome, Williams syndrome, all these are high-risk groups in which you should screen for celiac disease not only once, but every year if you need to. Those with selective IgA deficiency is almost 5 to 10 times higher in celiac disease population as compared to normal population. And of course, those with first-degree relatives, this is very common in our practice, where we do celiac screening for asymptomatic siblings of affected case. So let's start with the typical case. This is 10-year-old girl present with abdominal pain, diarrhea for the past 2 to 3 months. Pain is postprandial with lower abdominal location, happen 4 to 5 times per week. The stools are loose and explosive with no blood or mucus. Defecation provides pain relief, so no loss of appetite, no loss of weight, no family history of note. Examination is completely normal. Typical case we see in our clinic. This is TTG, which is negative, less than 20. TTG IgG was slightly positive. Anti-endomycin antibody was negative. Anti-deaminated gliadin peptide, which is the new generation of anti-gliadin antibodies. IgA is negative and IgG slightly positive. So based on this data, so your response will be 1 out of 4. You diagnose celiac disease and start a gluten-free diet. You diagnose irritable bowel syndrome and treat accordingly. You test for celiac genes with HLA DQ2, DQ8, or refer to GI for biopsy. Based on this finding and the history that's suggestive of irritable bowel syndrome, I will diagnose this child as irritable bowel syndrome and treat accordingly. These are very valid and common questions we see in practice related to celiac disease. Is a panel of tests for celiac disease better than a single test? We will answer this question. What is the significance of isolated abnormal IgG-based celiac test in this case? When should be the celiac gene we requested? Is it okay to just try gluten-free diet? So to diagnose celiac disease is like a puzzle. So you need a clinical suspicion, you need a serological marker, you need a intestinal biopsy in almost all cases, and you need dietary response. These are common commercially available serological tests that we use in practice. Anti-gliadin antibody, IgG and IgA, this used in the 90s and 80s, and we don't use them anymore because of the low sensitivity and the specificity. Anti-endomycin antibody is very good test with high positive predictive value. Tissue transglutaminase antibody, especially IgA, is the most cost-effective screening test for celiac disease. And again, anti-deaminated gliadin peptide, IgG and IgA, are very good, especially in young children below the age of 5. This is the sensitivity and specificity of different commercially available tests for celiac disease. And you can see anti-gliadin antibodies, IgG and IgA, tend to be on lower sensitivity and specificity bar. Anti-endomycin antibody are very good with high positive predictive value, high specificity, and good sensitivity. And TTG IgA is the best in terms of sensitivity and specificity. If you have a choice to choose one test for screening test for celiac disease, you go with TTG IgA and total IgA. Bottom line, you choose TTG IgA and serum IgA level alone. This is most cost-effective and reliable initial test for celiac disease. For special consideration, those with selective IgA deficiency, usually we go with the IgG-based tests like TTG, IgG, anti-endomycin antibody, IgG, or anti-deaminated gliadin peptide, IgG, and consider biopsy if you are not sure and you have a strong clinical suspicion that this child might have celiac disease. These are the causes of false negative tests, especially IgA-based, so age less than 2, possible lab error, reduction or elimination of gluten from the diet. So that's why we instruct the parents to be on a gluten-containing diet or normal diet for at least 2 to 3 months prior to doing the test or intestinal biopsy. Those with selective IgA deficiency, if you use corticosteroid or immunosuppressive medication, this might alter the result of serology. This is the other question. What is the significance of isolated abnormal IgG-based test? And this is what happened in this case, slightly positive IgG, TTG, and DGB. Looking at the literature, in screening for celiac disease, deaminated gliadin rarely predict disease when tissue transglutaminase is normal. Lack of utility of anti-TTG IgG based to diagnose celiac disease when anti-TTG IgA is negative. You get isolated elevation of IgG based antibodies are not indicative of celiac disease when TTG IgA is negative and serum IgA is normal. This is endoscopic finding of celiac disease. On the left side, you get normal appearing duodenal mucosa, and the second part, very nice mucosal folds, shiny and good with normal villi. And then you get scalloping or toothing when you get a loss of mucosal folds and nodularity. These are not pathognomonic. for celiac disease, but they are suggestive. This is very nice picture of histopathology taken from the second part of duodenum. You can see very nice finger-like projections or villi, and you get crypts, you get goblet cells, you get normal intraepithelial lymphocytes, less than 30 per intraepithelial lymphocytes per 100 enterocyte. And this is what happened in celiac disease with flattening, villus atrophy. You get intraepithelial lymphocytosis, plasma cell infiltrate, and crypt hyperplasia. What about, using HLA genes to diagnose celiac disease? So you have to understand a little bit of background that in general population, celiac disease is present in 1% in prevalence-based data based on biopsy. Family members, this is, raised to 1 to 10%. Identical twins is 70%, and non-identical twins is about 30%. And this is, when you put it in a chart, this is what you can see. So HLA-DQ2Q8, this is necessary but not sufficient to cause the disease. You need to have a genetic susceptibility, and then you have environmental triggers to have celiac disease. So the bottom line here that non-HLA genes cannot be used to diagnose celiac disease. You can have HLA-DQ2, DQ8 alleles and not have celiac disease because this will exist in 30 to 40% of general population. If you don't have the genetic makeup, which with HLA-DQ2 and DQ8, you almost cannot have celiac disease. So the bottom line that HLA genes can be used to exclude celiac disease, but not to diagnose it. High negative predictive value. What about a gluten-free diet? Should we give it for everyone? So there are many indications for gluten-free diet, either for medical necessity, like wheat allergy. This is IgE-mediated disease, exists in 0.1% of population. Celiac disease, which is gluten-sensitive neuropathy, exists in 1% of population. And then we have non-celiac gluten sensitivity. This happens in 5 to 6% of population, but this is diagnosis of exclusion if you exclude celiac disease by intestinal biopsy and exclude wheat allergy by doing skin prick test and IgE-specific test to gluten and wheat. What are the implications to diagnose celiac disease? So the mandate of strict gluten-free diet for life, this is a huge burden on the family, requires input from a registered dietitian with experience in celiac disease, requires a regular follow-up on monitoring for compliance. You need to follow their mental well-being, their growth, their symptoms, and you need to follow their serology markers as well. And you fail to do so with compliance, this will lead to adverse long-term health implications and consequences, including a nutritional deficiency and risk of cancer, especially breast, thyroid, or T-cell lymphoma of the intestine. What are the downsides of gluten-free diet? So expensive, constant vigilance, it limits social interaction, and also hidden sources of gluten, not only in the diet, but also in medications, and makeup, and toothpaste, and many other preparations. And what are the nutritional facts regarding gluten-free diet? It is less nutritious, so these children need to be monitored for nutritional deficiency. They need to give a multivitamin supplement. There is a potential exposure to arsenic. There is higher in calories, so usually these children gain a lot of weight because they depend on fat and sugar. And also they are higher on sodium, so also increased cost and constant vigilance looking at the manufacturer labeling of all food material. What about the quality of life, especially in teenagers? What do you least like, about a gluten-free diet? They cannot enjoy eating with friends, even during travel. It's a hassle for them. They have to get a bag full of gluten-free products because not all countries will have all preparation of a gluten-free diet in the market. Also, they have to check everything before they eat. Bottom line, putting children on strict gluten-free diet for life is a big deal. This is why you have to have a rigid diagnosis with serology, with symptoms, and with small bowel biopsy. Finally, I would like to conclude how to differentiate between different between gluten-related disorders, starting with the celiac disease, with clinical symptoms, serological markers, intestinal biopsy, and response to diet. This is very common and easy and straightforward. Those with wheat allergy, usually they present with the skin or some GI manifestations. They need a skin prick test. They need allergic specific IgE, especially to wheat. and they need oral food challenge, which is the gold standard to diagnose wheat allergy, which is IgE-based condition. If you don't have celiac disease or you don't have wheat allergy, this is when you label your child or your adolescent as non-celiac disease gluten sensitivity, and this is usually a diagnosis of exclusion. And usually you challenge them, and it needs double-blinded, placebo-controlled food challenge to diagnose this condition. And usually you exclude wheat for a couple of weeks, 4 to 6 weeks, and look at the response, and then slightly reintroduce wheat and look at the tolerance of symptoms. And you might also give them low FODMAPs diet. Thank you very much for your attention, and thank you very much for your listening. And
thank you, Professor Alrefaee. Actually, many thanks for our honored speakers. We had 4 wonderful talks. Thanks to my co-chairperson. And if you have any question to Dr. Alrefaee, please. Thank you, Dr. Alrefaee. We don't have a question right now. Unfortunately, we will close the session. And may I call the speakers and chairperson for the next session.